Hello, hello. All right, today I'm going to talk about one particular medication, Abilify or aripiprazole. And the reason I'm going to talk about this medication is because I have some potentially heterodox opinions about it, but also I think it's a very commonly used medication in psychiatry, and so it's good to review. So I'm going to be just reviewing the general prescribing information for oral aripiprazole, and I'm also going to discuss some of the long-acting injectable formulations, again, referring to the official prescribing information. Before I get started, I did want to just throw out that I think it's really useful to actually look at the official FDA label, also called the package insert or just the prescribing information. It's usually found as a PDF. If it's a brand name medication, there's usually a official website for the medication. For example, Caplyta has the website that's caplyta.com. And at the top, you'll see prescribing information. You click on that and you get a PDF with basically everything you need to know about prescribing that medication. For the generic medications, there's often not a website, but if you just type in like aripiprazole FDA label, that's usually how I find it. And then you can get the prescribing information that way. You do want to make sure that you're looking at a up-to-date one. It's usually updated every a few years at least. You can also go to the official FDA website and there's a search feature and you can find these too. But I actually prefer looking at these prescribing information labels for learning how to prescribe these medications as opposed to textbooks because it's really just got everything you need in there. It's got the clinical trial data. It's got the pharmacology. It's really got everything you need except from anecdotal clinical experience. So there's lots of things that we do that might not adhere to the guidelines in these package inserts, but seem to work anecdotally. For example, I have had no problems dosing clozapine all at nighttime, even though the official FDA prescribing guidelines say that you're supposed to dose it twice daily. I just go a bit slower, but in terms of tolerability and not zonking people out throughout the whole day, I've found that to be more tolerable. But in any case, I think in general, the official prescribing guidelines are really useful to look at and familiarize yourself with for medications that you're going to be using. All right. So anyways, aripiprazole, that's the generic name. Abilify is the brand name. It is indicated. That means the FDA has said that this drug can be marketed for the following conditions. One is schizophrenia. Two is the acute treatment of manic and mixed episodes associated with bipolar 1 disorder. Three is the adjunctive treatment of major depressive disorder. Four is irritability associated with autistic disorder. And five is the treatment of Tourette's disorder. So those are the 5 official indications for aripiprazole or Abilify. The aripiprazole comes in either 2, 5, 10, 15, 20, or 30 milligram tablets. And usually for most of these conditions, you're going to be starting off somewhere in the range of 2 to 5 milligrams. In the outpatient setting, I'm usually starting off at 2 milligrams. On the inpatient setting, maybe more likely to start at 5. If you're treating something like acute mania or schizophrenia, it's very reasonable to start off right at 10 milligrams, potentially even 15 milligrams. And then the maximum dose for most of these conditions is 30 milligrams, although for its use as an adjunct in depression, it's 15 milligrams. So aripiprazole is a partial dopamine agonist. And so it has the interesting ability to be sort of pro-dopaminergic and anti-dopaminergic at the same time, probably in different pathways, and just depending on the endogenous dopamine activity and things like that. So unlike most antipsychotics, it has a particular potential side effect or risk, which is pathological gambling and other compulsive behaviors. And I have definitely seen this a few times in clinical practice. And this is also associated with dopamine agonists that you might see in Parkinson's disease. So that's a interesting difference from some of the other pure dopamine antagonist drugs like, say, risperidone. But nonetheless, it shares many of the other risks and warnings and precautions that the other antipsychotics have. And some of those are just family class warnings. So there's increased risk of cerebrovascular accidents in elderly patients with dementia-related psychosis. And there's the possibility of neuroleptic malignant syndrome, tardive dyskinesia, metabolic issues, metabolic syndrome, orthostatic hypotension, potentially leukopenia, neutropenia, seizures, suicide, and cognitive and motor impairment. I can't say that I've ever seen anybody get tardive dyskinesia from aripiprazole. Now, maybe I've just been lucky, but I've certainly seen tardive dyskinesia from most of the other antipsychotics, saving for quetiapine and clozapine. Pretty much all the strong, pure dopamine antagonist drugs. I've definitely seen tardive dyskinesia from those. However, that doesn't mean it can't happen. I've definitely seen acute dystonic reactions from aripiprazole and, acute extrapyramidal symptoms from aripiprazole. But for whatever reason, I've never seen tardive dyskinesia. So I'd be curious if other people have. You can leave a comment on the Substack. I'd be curious. Well, one thing that I wanted to say in particular was its use for depression. So this is kind of my peculiar position on it. So as I mentioned earlier, it is FDA approved for mania in bipolar disorder, but not depression in bipolar disorder. But it is used as an adjunct to antidepressants in major depressive disorder. So why is that? Does it really not work in bipolar depression? Or do you have to take the risk of combining it with a traditional antidepressant, which is generally code for one of the serotonergic medications? So aripiprazole, as I recall, and I'm not looking at the study right now, so this might be a little bit off, but it should be directionally true. Aripiprazole was studied in bipolar depression. There was a clinical trial for it. And they, if I recall correctly, the dose was relatively high in that study. They were using doses similar to how you might treat acute mania, like 10 to 15 to 20 milligrams a day. And in that study, they didn't find a significant benefit of aripiprazole for depression. Now, personally, I have used aripiprazole quite a bit and have found it to be useful in bipolar depression. I'll say more bipolar 2 than bipolar 1, and those might be truly more distinct conditions. But I do find it to be useful anecdotally. And I've also found it to be useful as a monotherapy in unipolar depression. And I've given my sort of thoughts on the distinction between unipolar and bipolar depression in a prior episode. But basically, if you didn't listen to that one, I think for people that have truly fairly unprovoked mood episodes, whether they're depressive or manic or whatever, that it falls on just the spectrum of manic depression that it used to be called by Emil Kreklin. And that's, a lot of maybe what we call major depressive disorder is often very triggered by some psychosocial situation, and oftentimes is maybe better characterized as adjustment disorder. I think we underuse the diagnosis of adjustment disorder and overuse MDD as a diagnosis. But anyways, so because aripiprazole is a partial agonist and can both enhance and antagonize dopamine activity in certain pathways, and we know some of the other dopamine agonists have been useful in depression, such as Mirapex, which is pramipexole, it makes sense that aripiprazole might be helpful in depression in some folks. So, and that's been my experience. Now, I dose it low. So I pretty much, if I'm using depression, I'm using aripiprazole for depression. I'm usually starting at 2 milligrams and then maybe going up to 4, then 5. I'm usually never going any higher than around 7 milligrams. And my guess is that, once you start going over 10 milligrams or so, it's starting to become more of a general dopamine antagonist, and rather than a enhancer or modulator. And then you're going to, either see a plateau of effect or potentially cause the opposite. So those are my thoughts on aripiprazole. So and I think it comes down to, like I mentioned in a prior episode, it comes down to triaging based on severity and acuity. So if someone, whether inpatient or outpatient, if someone is in a very severe depressive episode, then I'm probably not going to wait around for sertraline, say, to take effect in, 3, 4, 5, 6 weeks. I'm going to maybe consider going straight to aripiprazole, 2 to 5 milligrams. Now, of course, I'm going to go through informed consent. I'm going to tell the patient that this is not FDA indicated for that necessarily, but this is my experience. So I'm going to tell them all of that. Most of the time, patients are like, yeah, I think that makes sense. I want to get better faster. I don't want to wait around 4 to 6 weeks. And in my experience, I've had patients get better within probably the earliest is 3 or 4 days with aripiprazole. Now, of course, I'm not running randomized control trials. Could that be placebo? Yes, but I generally don't see that rapid of a response with sertraline or the SSRIs, uh, even factoring in placebo effects and things like that. And the effect seems to stay. And then we've tried backing off the dose or coming off of it, and brushing comes back. So I don't know, you can never be 100% sure, if you're not doing rigorous science here, but I feel fairly convinced that aripiprazole, even monotherapy, can be effective in a good percentage of people with unipolar depression and bipolar depression too, although I would say more on the bipolar 2 spectrum. In terms of dosing, I typically dose in the morning, especially if I'm using those low doses, the 2 to 5 milligrams. Most of the time, aripiprazole is not sedating. In fact, in some cases, it can be activating, but usually in my experience, maybe 10 or 20% of folks will find it sedating. And so I just tell them if that's the case to switch to taking it at nighttime. And that seems to work pretty well. Now, keep in mind, aripiprazole has a very long half-life. The half-life is like somewhere in the range of 70 to 90 hours or something like that. And it's metabolized by the CYP2D6 enzyme primarily, and also 384. So those are just other things to keep in mind. Another risk that I always tell my patients about on aripiprazole is the risk of akathisia, because this is, it's obviously not the majority of people that get it, but it's common enough that I think that's definitely worth mentioning in your informed consent process. And usually how I explain it is, I will ask the patient, have you ever heard of restless leg syndrome? I'd say most people have heard of restless leg syndrome. And if they haven't, I give a brief explanation of it. And then I describe akathisia as like a full body restless leg syndrome. So instead of just your legs feeling restless, your whole body feels restless. And it can be very uncomfortable, like you want to crawl out of your skin. And aripiprazole is really effective for the depression, but they're having a side effect like akathisia. There are ways around that. And so we can give some medications. Propranolol, mirtazapine, or a benzodiazepine are usually the go-tos for treating akathisia if you have to stay on the medication. And now I want to transition into the long-acting injectable forms of aripiprazole, because that's one big advantage to using this medication if you're treating bipolar 1 disorder or schizophrenia, whether outpatient or inpatient, for folks that have difficulties with medication adherence or just prefer it. And some people just prefer it, even if they are able to take a medicine consistently every day. Okay, let me start with Abilify Maintena. So Abilify Maintena is a long-acting injectable. It's useful and simple because it basically only comes in one dose, although, well, it comes in 400 milligrams or 300 milligrams, but basically most people are getting it 400 milligrams. So the dosing is pretty simple. Of course, with any of these long-acting injectables, you're going to want to establish tolerability and probably efficacy with oral aripiprazole. And because aripiprazole has that long half-life, 70-something hours, it could take a couple of weeks before you could really say that they're going to tolerate it before it reaches steady state. Now, most of the time, if you're on the inpatient setting, you're not going to have the luxury of waiting for a couple of weeks. So many times they will do it earlier than that, especially, when they've got good family support and you've got a good aftercare set up. But ideally, that would be the recommendation, as you wait a couple of weeks. There's 2 ways to initiate treatment with Abilify Maintena. One is to administer 2 separate injections of Abilify Maintena 400 milligrams, along with a single oral dose of aripiprazole 20 milligrams. And then you just, from there, you can give, the maintenance injections every month after that. The other way would be to do one 400 milligram injection and then continue their oral aripiprazole, which is generally going to be in the range of 10 to 20 milligrams a day for 14 days before you have them come off of it. The other long-acting injectable is, there's two others that we're going to talk about. One is Abilify Aristada. And so that is just another long-acting injectable, comes in more dose options. So that's an advantage of that one. And it can also be administered at longer intervals. So Aristada can be initiated at a dose of 441 milligrams, 662 milligrams, or 882 milligrams every month, or 882 milligrams every 6 weeks, or 1,064 milligrams every 2 months. So that gives you more options. There's two ways to start treatment with Aristada. The first option is to give Aristada Initio, which is just another branded injection that's used just to start this injection, the maintenance injections. So Aristada Initio 675 milligrams is given along with a single dose of oral aripiprazole 30 milligrams, in addition to whatever dose you're choosing for the Aristada. So for example, you could give Aristada 441 milligrams along with Aristada Initio 675 milligrams along with the 30 milligrams of oral aripiprazole. You can do both of those injections on the same day, or you could give the Aristada injection up to 10 days after the Initio injection. Option 2 is to give the Aristada injection and continue 21 days of oral aripiprazole, and then they can come off it. So that's the other long-acting injectable. It just got more dosing options. You can go every 2 months if you need to, so that's nice. But it's a little less simple to use than Maintena. And then the newest long-acting injectable formulation of aripiprazole is Abilify Asimtify. And yeah, this is a newer one. I think I've only used it once or twice, so I haven't had a ton of experience with it so far. But it also has two ways to initiate treatment. So one way is to give the Abilify Asimtify 960 milligram injection along with Abilify Maintena 400 milligrams injection and a single oral dose of aripiprazole 20 milligrams. And then you can do all of that on one day and then immediately transition into maintenance injections. The other option is to give Abilify Asimtify 960 milligrams injection on day one and then continue their oral aripiprazole, again in that 10 to 20 milligram range for 14 days. Abilify Asimtify is also fairly easy to use, similar to Abilify Maintena, because it also has basically one or two dosing options. So most people are going to be on the 960 milligrams once every 2 months, or you can reduce it down to 720 milligrams if people are having some side effects. So it's newer, less accessible, but also easy to use and longer injection intervals. All right, well, that's pretty much everything I wanted to say about Abilify for the time being. So take care.